What are the four principles of medical ethics and how do they apply to a physician's decision-making process in clinical practice? Answer: the four principles of medical ethics are autonomy, beneficence, non-maleficence, and justice. Autonomy. This principle asserts that patients have the right to make informed decisions about their own healthcare. Physicians must respect the patient's preferences and choices after providing all necessary information about risks and benefits. Beneficence. Physicians are obligated to act in the best interest of the patient, promoting their well-being and taking positive steps to improve their health. Non-maleficence. This principle dictates that healthcare providers should not harm the patient, and in practice, this means carefully weighing the benefits and risks of treatment options to avoid causing harm. Justice. This principle involves fairness in the distribution of healthcare resources. It calls for equitable treatment of patients regardless of their background, including considerations of socioeconomic status, race, and other factors. In clinical decision-making, these principles guide physicians to consider not just the medical outcomes, but also the ethical implications of their actions. For example, when discussing treatment options, a physician must ensure that the patient understands the implications. Autonomy, that the treatment is beneficial. Beneficence, that it will not cause harm. Non-maleficence, and that it is equitable. Justice. Discuss the significance of informed consent in the context of medical ethics. What elements must be present for informed consent to be valid? Answer: informed consent is a fundamental ethical and legal requirement in healthcare that ensures patients are fully aware of and understand the nature of their treatment before agreeing to it. The significance of informed consent lies in its role in upholding patient autonomy and establishing trust in the physician-patient relationship. For informed consent to be valid, several key elements must be present. Competence. The patient must be mentally competent to make decisions regarding their treatment. This involves assessing the patient's ability to understand the information provided. Disclosure. The physician must provide comprehensive information about the proposed treatment, including its purpose, risks, benefits, alternatives, and potential outcomes. Understanding. The patient must demonstrate an understanding of the information presented. This can be evaluated through discussion and ensuring the patient can articulate their understanding. Voluntariness. The patient must give consent voluntarily without coercion or undue pressure from healthcare providers or family members. Consent. The final element is that the patient must explicitly agree to the treatment after receiving and understanding all relevant information. Explain how cultural competence impacts the physician-patient relationship and the delivery of healthcare services. Answer: cultural competence refers to a healthcare provider's ability to understand, communicate with, and effectively interact with patients from diverse cultural backgrounds. Its impact on the physician-patient relationship and healthcare delivery is significant for several reasons. Improved communication. Culturally competent providers can communicate more effectively with patients using language and concepts that resonate with the patient's cultural context. Tailored care. Recognizing cultural differences allows physicians to tailor their care to meet the specific needs and preferences of patients. For instance, dietary restrictions based on religious beliefs can influence treatment plans. Patient engagement. When patients feel understood and respected, they are more likely to engage in their care, follow treatment plans, and return for follow-up appointments. Reduction of health disparities. Cultural competence can help address and reduce health disparities by ensuring that all patients receive equitable care regardless of their cultural background. Ethical practice. Understanding cultural values and beliefs supports ethical decision-making as it enables healthcare providers to respect the autonomy and values of their patients. Mr. Smith is a 65-year-old patient with multiple chronic conditions who has been advised to start a new medication that has a significant risk of side effects. He appears anxious about the medication and expresses concern about the potential impact on his daily life. As his physician, what steps should you take to address his concerns while ensuring compliance with the principle of informed consent? Answer: in this scenario, as Mr. Smith's physician, you should take the following steps. Assess understanding. Begin by assessing Mr. Smith's understanding of his condition and the new medication. Ask open-ended questions to gauge his concerns and perceptions about the treatment. Provide information. Clearly explain the purpose of the medication, its benefits, potential side effects, and alternative treatment options. Use simple language and avoid medical jargon to enhance understanding. Encourage questions. Invite Mr. Smith to ask questions about the medication and his treatment plan. This fosters a two-way conversation and helps clarify any misunderstandings. Discuss concerns. Address his anxieties by discussing how the medication may affect his daily life. Offer reassurance by explaining the monitoring plan and strategies to manage potential side effects. Explore alternatives. If appropriate, discuss alternative treatments that may have fewer side effects, allowing Mr. Smith to weigh his options thoroughly. Document the discussion. Document the conversation in his medical record, noting his questions, concerns, and the information provided. This ensures compliance with informed consent requirements. Give time. Allow Mr. Smith time to consider the information and encourage him to reach out with any further questions or concerns before making a decision. By following these steps, you uphold the principles of informed consent, ensure Mr. Smith's autonomy is respected, and promote shared decision-making in his care. What role does quality improvement play in healthcare systems, and how can it impact patient safety initiatives? Answer: quality improvement (CAI) plays a crucial role in healthcare systems by systematically enhancing the effectiveness and efficiency of care delivered to patients. The key aspects of quality improvement include identification of areas for improvement. QI initiatives begin with the identification of specific areas within healthcare delivery that require enhancement, such as reducing hospital readmission rates or improving patient satisfaction scores. Data collection and analysis. QI relies heavily on data collection and analysis to understand the current performance levels and to identify gaps in care. This includes measuring patient outcomes, process efficiencies, and adherence to clinical guidelines. Implementation of changes. Based on the analysis, healthcare providers can implement evidence-based changes aimed at improving processes and outcomes. This could involve revising protocols, increasing staff training, or enhancing communication practices. Monitoring outcomes. Continuous monitoring is essential to assess the effectiveness of the changes made. By regularly reviewing outcomes and processes, healthcare organizations can determine if improvements are sustained over time. Patient safety initiatives. QI directly impacts patient safety by fostering a culture of safety within healthcare organizations. Initiatives may include standardizing medication administration processes, improving hand hygiene compliance, or implementing checklists for surgical procedures to reduce errors. Overall, quality improvement is vital for creating safer healthcare environments, improving patient outcomes, and ensuring that care delivered aligns with best practices and patient needs. Discuss the importance of confidentiality in the physician-patient relationship. What legal frameworks support patient privacy in the healthcare setting? Answer: confidentiality is a cornerstone of the physician-patient relationship, fostering trust and open communication. It is essential for several reasons. Trust building. Patients are more likely to share sensitive information when they trust that their privacy will be respected. This openness is crucial for accurate diagnosis and effective treatment. Ethical obligation. Physicians have an ethical duty to protect patient information as outlined in the principles of medical ethics. Respecting confidentiality aligns with the principle of autonomy. Legal requirements. Various legal frameworks govern patient privacy and confidentiality in healthcare settings. The most significant are Health Insurance Portability and Accountability Act (HIPAA) in the United States. HIPAA establishes national standards for the protection of health information. It requires healthcare providers to implement safeguards to ensure the privacy and security of patients' medical records and personal health information. State privacy laws. In addition to federal laws like HIPAA, many states have their own privacy laws that may provide additional protections for specific types of health information or impose stricter confidentiality standards. Common law duty of confidentiality. Beyond statutory requirements, there exists a common law duty that mandates healthcare providers to keep patient information confidential unless consent is given to disclose it, or there are legal exceptions. Violations of confidentiality can lead to legal repercussions, loss of trust, and harm to the patient-physician relationship. Therefore, healthcare providers must be well versed in both ethical standards and legal obligations to maintain confidentiality. How does the physician-patient relationship contribute to effective clinical decision-making, and what factors can hinder this relationship? Answer: the physician-patient relationship is fundamental to effective clinical decision-making. It influences the patient's willingness to share information, adhere to treatment plans, and engage in discussions about their health. Key contributions of this relationship include enhanced communication. A strong relationship fosters open communication, allowing patients to express their concerns and preferences. This dialogue enables physicians to make informed decisions that align with patients' values. Shared decision-making. An effective relationship promotes shared decision-making, where both the physician and patient collaborate to choose the best treatment options based on clinical evidence and the patient's preferences. Increased adherence. Patients are more likely to adhere to treatment plans when they trust their physician and feel involved in the decision-making process. However, several factors can hinder the physician-patient relationship. Cultural differences. Differences in language, beliefs, or values can create barriers to effective communication and understanding. Time constraints. Busy schedules may limit the time available for thorough discussions, potentially leading to misunderstandings or a lack of comprehensive informed consent. Patient anxiety. Patients experiencing anxiety or fear about their health may withhold information or struggle to engage fully in discussions, impacting the quality of the decision-making process. Burnout. Physician burnout can negatively affect the quality of care, leading to less empathetic interactions and decreased patient satisfaction. By recognizing and addressing these factors, healthcare providers can strengthen the physician-patient relationship and enhance the quality of clinical decision-making. What ethical considerations must physicians take into account when dealing with vulnerable populations in healthcare settings? Answer: when working with vulnerable populations, physicians must navigate various ethical considerations to ensure equitable and just care. Key considerations include informed consent. Vulnerable populations may face challenges in understanding medical information due to language barriers, cognitive impairments, or socioeconomic factors. Physicians must ensure that informed consent is obtained in a manner that is clear and comprehensible, adapting communication styles as needed. Justice and equity. Physicians have an ethical obligation to provide fair and equitable treatment. This includes advocating for access to healthcare services for marginalized groups and addressing systemic barriers that may affect their care. Beneficence and non-maleficence. Care must be tailored to the specific needs of vulnerable populations, ensuring that interventions are beneficial and do not cause harm. Physicians should be particularly sensitive to potential exploitation or coercion in vulnerable groups. Confidentiality. Protecting the privacy of vulnerable patients is critical, especially when they may face discrimination or stigmatization based on their health status, socioeconomic background, or other factors. Cultural competence. Understanding the cultural context of vulnerable populations can improve patient-provider relationships and health outcomes. Physicians must be aware of cultural differences and respect patients' beliefs and practices. By incorporating these ethical considerations, physicians can provide compassionate, respectful, and equitable care to vulnerable populations. How can healthcare policy impact the delivery of quality care, and what role do physicians play in advocating for policy changes? Answer: healthcare policy plays a critical role in shaping the delivery of quality care by establishing frameworks that govern access to services, reimbursement models, and the allocation of resources. Key impacts of healthcare policy include access to care. Policies can determine who has access to healthcare services, affecting uninsured or underinsured populations. Expanding coverage through initiatives like Medicaid can improve access and overall health outcomes. Quality standards. Healthcare policies often set quality standards and performance metrics that providers must adhere to, promoting continuous quality improvement and patient safety initiatives. Resource allocation. Policies influence how resources are allocated within healthcare systems, which can impact the availability of services and the distribution of healthcare professionals across regions. Reimbursement models. The structure of reimbursement, e.g., fee-for-service versus value-based care, affects how healthcare providers deliver care, incentivizing or disincentivizing certain practices. Physicians play a vital role in advocating for policy changes that promote quality care by engagement and advocacy. Physicians can participate in professional organizations, contribute to policy discussions, and advocate for reforms that improve patient care and public health. Research and evidence generation. By engaging in research, physicians can provide evidence-based recommendations that inform policy decisions and address gaps in care delivery. Collaboration with policymakers. Building relationships with policymakers allows physicians to influence legislation that affects healthcare delivery and outcomes. Overall, physicians have the responsibility to engage with healthcare policy actively, ensuring that it aligns with the principles of quality care and addresses the needs of their patients. What are the principles of quality improvement in healthcare, and how do they relate to patient safety initiatives? Answer: the principles of quality improvement (QI) in healthcare are designed to enhance the overall effectiveness and safety of patient care. Key principles include patient-centered care. Quality improvement initiatives should prioritize the needs and preferences of patients, ensuring that care is tailored to individual circumstances. Data-driven decision-making. QI relies on collecting and analyzing data to identify areas for improvement. This includes tracking patient outcomes, measuring adherence to clinical guidelines, and understanding patient satisfaction. Continuous learning. Quality improvement emphasizes A culture of continuous learning and adaptation where healthcare providers regularly assess their practices and implement changes based on best evidence. Interdisciplinary collaboration. Effective quality improvement involves collaboration among healthcare professionals across disciplines, fostering a team-based approach to enhance care delivery. Focus on systems and processes. QI initiatives aim to improve healthcare systems and processes rather than attributing blame to individual providers. This perspective supports a safer, more effective care environment. These principles are closely related to patient safety initiatives, as both seek to reduce errors and improve outcomes. For example, implementing standardized protocols for medication administration, a QI initiative, directly contributes to minimizing the risk of medication errors, enhancing patient safety. By fostering a culture of quality and safety, healthcare organizations can provide better care for patients and improve overall health outcomes. 48-year-old man presents with chronic heartburn, regurgitation, and a bitter taste in his mouth, especially after meals. Discuss the management approach for his symptoms suggestive of GERD. Answer: management includes lifestyle modifications. Advise the patient to avoid trigger foods, e.g., spicy, fatty foods, and caffeine. Recommend weight loss if overweight and encourage smaller, more frequent meals. Suggest elevating the head of the bed and avoiding lying down for at least 2 to 3 hours after meals. Pharmacotherapy. Start a proton pump inhibitor, PPI, omeprazole, for symptom relief. Consider an H receptor antagonist if PP is not effective or suitable. Follow-up. Schedule a follow-up appointment to assess symptom improvement and evaluate for potential complications, e.g. esophagitis. A 65-year-old woman comes for her annual checkup. She has no significant medical history but has a family history of hip fractures. Discuss the recommendations for osteoporosis screening in this patient. Answer: recommendations include screening, perform a DEXA scan, dual energy X-ray absorptiometry to assess bone density, especially since she is over 65 and has a family history of fractures. Risk assessment: utilize the FRAX tool to calculate her 10-year fracture risk and assess the need for treatment. Prevention: recommend lifestyle modifications, including weight-bearing exercises and adequate calcium and vitamin D intake. Discuss pharmacologic options, e.g. bisphosphonates, if her DEXA results indicate osteoporosis. Follow-up: plan for repeat DEXA scans every 1-2 years based on initial results and treatment response. A 58-year-old woman with type 2 diabetes presents with elevated serum creatinine and proteinuria. Discuss the management approach for her chronic kidney disease. Answer: management includes assessment. Stage her CKD based on estimated glomerular filtration rate, EGFR, and proteinuria levels. Blood pressure control. Initiate SCE inhibitors or ARBs to manage hypertension and reduce proteinuria. Glycemic control. Optimize her diabetes management to slow CKD progression. Dietary modifications. Recommend dietary adjustments to reduce protein intake and manage sodium and potassium levels. Follow-up. Schedule regular follow-ups to monitor renal function, electrolytes, and adherence to lifestyle changes. A 65-year-old woman presents with knee pain and stiffness that worsens with activity and improves with rest. Discuss the management of her osteoarthritis. Answer: in a hypertensive emergency characterized by severely elevated blood pressure, BP, and signs of acute end organ damage, immediate management is critical. The first step is to ensure the patient's stability, including obtaining a thorough history, physical examination, and necessary laboratory tests to assess for end organ damage, such as renal impairment, heart failure, or neurological deficits. Immediate blood pressure control. Initiate treatment with intravenous antihypertensives to achieve a rapid but controlled reduction in BP. Suitable agents include nitroglycerin for patients with cardiac complications, sodium nitroprusside, potent vasodilator, or libitalol, a combined alpha and beta blocker. The goal is to reduce the mean arterial pressure MAP by 0.25% within the first hour. Careful monitoring is necessary to avoid excessively rapid reductions, which can precipitate ischemic events. Assessing and treating underlying causes. Evaluate for potential causes of secondary hypertension, such as renal artery stenosis or pheochromocytoma, and address them accordingly. In this case, the patient's headache and visual changes may suggest hypertensive encephalopathy, requiring a prompt focus on neurological evaluation. Supportive care. Ensure the patient is in a quiet, dimly lit environment to alleviate headache symptoms and provide reassurance. Consider the use of analgesics for headache relief and monitor vital signs and neurological status frequently. Transition to oral therapy. Once BP is stabilized, transition to oral antihypertensive therapy and provide education on lifestyle modifications and medication adherence to prevent recurrence. A follow-up with a primary care physician should be arranged to monitor long-term management. A 50-year-old woman presents with fatigue and pallor. Lab tests reveal hemoglobin of 9 grams still and microcytic anemia. Discuss the management of her condition. Answer: the management of microcytic anemia, commonly due to iron deficiency, begins with confirming the diagnosis and determining the underlying cause. In this case, the patient presents with symptoms indicative of anemia, fatigue, pallor, and lab results showing low hemoglobin and microcytic red blood cells. Further evaluation. Conduct additional tests including serum ferritin transferrin saturation and total iron binding capacity (TIC) to assess iron stores and confirm iron deficiency. Consider other potential causes of microcytic anemia, such as thalassemia or anemia of chronic disease. Iron supplementation. Initiate oral iron supplementation with ferrous sulfate 325 mg orally once or twice daily for iron deficiency anemia. It's essential to counsel the patient about potential side effects, e.g. gastrointestinal upset, constipation, and advise taking iron with vitamin C, e.g. orange juice, to enhance absorption. Dietary modifications. Encourage dietary changes to include iron-rich foods, such as red meat, poultry, fish, lentils, beans, and leafy greens, while also discussing the importance of vitamin C-rich foods to enhance non-heme iron absorption. Monitoring and follow-up. Schedule follow-up appointments to monitor hemoglobin levels and reticulocyte count after 4-6 weeks of iron therapy. Improvement in hemoglobin should occur within this time frame. If there is no response, further investigation may be warranted to rule out other causes of anemia. Consider additional treatment. If the patient has difficulty tolerating oral iron or has significant iron deficiency that requires more aggressive treatment, consider intravenous iron therapy. A 70-year-old woman is diagnosed with osteoporosis following a bone density scan. Discuss the management strategies for her condition. Answer: the management of osteoporosis focuses on fracture prevention and improving bone health through pharmacologic and non-pharmacologic strategies. After diagnosis based on bone mineral density (BMD) testing, the following steps should be taken. Lifestyle modifications. Encourage weight-bearing and muscle strengthening exercises to improve bone density and balance, reducing the risk of falls. Promote adequate intake of calcium 1200 mg day and vitamin D 800 1000 a day through diet, dairy products, leafy greens, fortified foods, and or supplements as needed. Pharmacologic treatment. Initiate pharmacotherapy, typically with bisphosphonates, e.g. alendronate, ristronate, which inhibit bone resorption and have proven efficacy in reducing fracture risk. Administer these medications with specific instructions, such as taking them on an empty stomach with a full glass of water and remaining upright for at least 30 minutes afterward. Consider other treatment options based on patient factors, including denosumab, RANKL inhibitor, teriparatide, parathyroid hormone analog, or hormone replacement therapy in certain cases. Monitoring. Schedule regular follow-up appointments to monitor BMD and assess treatment efficacy. Consider re-evaluating BMD every 1-2 years depending on the patient's risk factors and treatment response. Patient education. Educate the patient about osteoporosis, the importance of adherence to treatment, and fall prevention strategies, e.g. home safety assessments, use of assistive devices if needed. Addressing secondary causes. Evaluate for potential secondary causes of osteoporosis such as hypothyroidism, chronic steroid use, or vitamin D deficiency and manage accordingly. 50-year-old male with a family history of coronary artery disease presents with a cholesterol level of 204 mg/L. Discuss the management strategy for his hyperlipidemia. Answer: the management of hyperlipidemia focuses on cardiovascular risk reduction through lifestyle changes and pharmacologic interventions. Given the patient's elevated cholesterol level and family history of coronary artery disease, a comprehensive approach is warranted. Lifestyle modifications. Emphasize dietary changes aimed at lowering LDL cholesterol, including adopting the DASH dietary approaches to stop hypertension, or Mediterranean diet, rich in fruits, vegetables, whole grains, lean proteins, and healthy fats, e.g. olive oil, nuts. Encourage regular physical activity, aiming for at least 150 minutes of moderate intensity exercise per week. Additionally, weight management should be emphasized if the patient is overweight. Pharmacotherapy. Based on the American College of Cardiology, American Heart Association, ACAHA guidelines initiate statin therapy e.g. atorvastatin or rosuvastatin to achieve a significant reduction in LDL cholesterol levels. Statins are particularly indicated in patients with a family history of premature coronary artery disease or established atherosclerotic cardiovascular disease. Assess the patient for potential statin side effects and consider alternative agents such as ezetimibe or PCSK inhibitors if additional LDL lowering is needed. Monitoring. Schedule regular follow-up visits to monitor lipid levels, typically every 1–2 months, and assess adherence to lifestyle and medication regimens. Patient education. Educate the patient about the importance of lifestyle modifications and medication adherence, discussing the role of cholesterol in cardiovascular health and the impact of family history on their risk profile. Risk assessment. Conduct a thorough cardiovascular risk assessment, including blood pressure, diabetes status, and smoking history, to tailor the management plan further and potentially initiate additional interventions such as aspirin therapy if indicated. A 65-year-old woman presents with dyspnea on exertion and edema. Discuss the management of her heart failure. Answer: the management of heart failure (HF) focuses on relieving symptoms, improving quality of life, and prolonging survival. This patient's presentation of dyspnea and edema suggests volume overload, typical in HF. Initial assessment. Conduct a thorough history and physical examination, including vital signs in the cardiac exam. Assess the New York Heart Association (NYHA) functional classification to determine the severity of HF and its impact on daily activities. Pharmacologic therapy. Initiate diuretics e.g. furosemide to manage fluid overload and alleviate symptoms of dyspnea and edema. Monitor renal function and electrolytes regularly, adjusting diuretic dosages as needed. Implement guideline-directed medical therapy (GMT), including an ACE inhibitor e.g. lisinopril or ARB, and a beta blocker e.g. carvedilol or metoprolol succinate for systolic heart failure (HFrEF). These agents improve outcomes and reduce hospitalizations. Lifestyle modifications. Advise dietary modifications such as sodium restriction and fluid management to reduce fluid retention. Recommend a heart-healthy diet rich in fruits, vegetables, whole grains, and lean proteins. Encourage regular physical activity tailored to the patient's functional capacity, promoting gradual increases in exercise levels as tolerated. Patient education. Educate the patient about recognizing signs of worsening heart failure e.g. increased dyspnea, sudden weight gain, and the importance of adherence to medications, lifestyle modifications, and follow-up appointments. Advanced therapies. Consider referral for advanced heart failure therapies such as implantable cardioverter defibrillator, placement, or heart transplantation if the patient meets specific criteria and continues to have symptoms despite optimal medical management. A 72-year-old woman with atrial fibrillation presents for evaluation of her stroke risk. Discuss the management plan for her. Answer: in managing a patient with atrial fibrillation (AF) and a risk of stroke, the focus is on stratifying the risk and initiating appropriate anticoagulation therapy to prevent thromboembolic events. Risk stratification. Use the CHA2DS2-VASc scoring system to assess the patient's stroke risk. Points are given for congestive heart failure, hypertension, age 75, diabetes, prior stroke, or transient ischemic attack tier vascular disease, age 6–5, 7–4, and sex category. A score of 2 or higher typically indicates the need for anticoagulation therapy. Anticoagulation therapy. If the patient has a CHA2DS2-VASc score of 2 or higher, initiate anticoagulation therapy. Options include direct oral anticoagulants, DOACs, such as apixaban or rivaroxaban, which offer advantages over warfarin in terms of monitoring and dietary restrictions. Assess renal function and contraindications before selecting the appropriate agent. Patient education. Educate the patient on the importance of medication adherence, recognizing signs of bleeding, and understanding the purpose of anticoagulation therapy and reducing stroke risk. Monitoring. Schedule regular follow-up appointments to monitor the efficacy of anticoagulation therapy and assess for any potential side effects, particularly bleeding complications. Management of risk factors. Address modifiable risk factors, including hypertension, diabetes, and hyperlipidemia, to further reduce the overall risk of cardiovascular events. Lifestyle modifications, dietary changes, and medication adjustments should be part of the management plan. Secondary prevention. If the patient has a history of stroke or TIA, ensure that additional secondary prevention measures, such as antiplatelet therapy, are discussed, although anticoagulation typically takes precedence in patients with AF. A 70-year-old man with a history of hypertension and diabetes presents with elevated serum creatinine levels. Discuss the management of his chronic kidney disease (CKD). Answer: the management of chronic kidney disease (CKD) involves addressing underlying causes, slowing disease progression, and preventing complications. In this patient with a history of hypertension and diabetes, a systematic approach is crucial. Assessment of CKD stage. Determine the stage of CKD based on the estimated glomerular filtration rate (EGFR) and the presence of proteinuria. This will guide management strategies. Control of blood pressure. Achieve strict blood pressure control, aiming for a target of 138 mmHg, particularly in patients with diabetes or CKD. Initiate or optimize antihypertensive therapy, often utilizing ACE inhibitors or angiotensin receptor blockers (ARBs) to provide renal protection and reduce proteinuria. Management of diabetes. Ensure optimal glycemic control, aiming for a C target of 7%. Just diabetes medications as necessary, considering the patient's renal function when prescribing agents like metformin or certain DAPA1 receptor agonists. Dietary modifications. Refer the patient to a registered dietitian for dietary counseling, focusing on a low-protein diet if stage 4 or 5 CKD, limiting sodium intake and ensuring adequate caloric and nutritional intake to prevent malnutrition. Monitoring and follow-up. Schedule regular follow-ups to monitor kidney function, EGFR and serum creatinine, electrolytes, and other relevant laboratory parameters, e.g., phosphate and bicarbonate levels. Just management based on these results. Addressing complications. Screen for and manage common complications of CKD, such as anemia, bone mineral disorders, and cardiovascular risk factors. Consider erythropoiesis-stimulating agents for anemia and phosphate binders or vitamin D supplementation for mineral bone disease. Patient education. Educate the patient about CKD, its progression, and the importance of medication adherence, lifestyle modifications, and regular follow-up appointments to monitor kidney function and overall health. What are the current recommendations for the influenza vaccine for adults, including considerations for special populations? Answer: the current recommendations for the influenza vaccine for adults include the following. Annual vaccination. All adults aged 18 years and older should receive the influenza vaccine annually. The vaccine is particularly important for individuals with chronic medical conditions, pregnant women, and those aged 65 years and older. Types of vaccines. Both inactivated IV and live attenuated influenza vaccines (LAV) are available. The quadrivalent vaccines are preferred as they provide protection against 4 virus strains. Timing. Vaccination should ideally occur before the onset of the flu season, usually by the end of October, but can be administered throughout the flu season as long as the virus is circulating. Special populations. Pregnant women should receive the inactivated vaccine at any stage of pregnancy due to increased risk of severe illness. Immunocompromised individuals should receive the inactivated vaccine only. LAIV is contraindicated. Older adults. High-dose influenza vaccines are available for those aged 65 and older, as they may provide improved immune response. What are the recommended screening strategies for colorectal cancer, including age recommendations and options available? Answer: the recommended screening strategies for colorectal cancer include starting age. Screening should begin at age 45 for average-risk individuals as recommended by the U.S. Preventive Services Task Force (USTF). Screening methods. Colonoscopy every 10 years considered the gold standard for screening. Flexible sigmoidoscopy every 5 years or every 10 years if combined with annual FIT, fecal immunochemical test, CT colonography, virtual colonoscopy every 5 years. Stool-based tests. Options include FIT annually, GFOP, guaiac-based fecal occult blood test annually, or multi-target stool DNA test every 3 years. Risk factors. Individuals with a family history of colorectal cancer or polyps, personal history of inflammatory bowel disease or genetic syndromes, e.g. Lynch syndrome, familial adenomatous polyposis, should start screening earlier and may require more frequent testing. End of screening. Screening may be discontinued at age 75 or if life expectancy is less than 10 years, depending on individual health status and prior screening history. Discuss the current guidelines for lipid management in adults, including criteria for statin therapy. Answer: current guidelines for lipid management in adults, as outlined by the American College of Cardiology and American Heart Association, include statin therapy initiation. Individuals with atherosclerotic cardiovascular disease. High-intensity statin therapy is recommended. Individuals with an LDL level equal 109 mdl, high-intensity statin therapy is indicated regardless of age. Individuals aged 40-75 years with diabetes, moderate intensity statin therapy is recommended. Individuals aged 40-75 years without diabetes but with an estimated 10-year ASCVD risk of 20% or higher, high-intensity statin therapy is recommended. Monitoring. Lipid levels should be assessed after initiating statin therapy, typically within 4-2 weeks and at least once every 3-2 months thereafter to ensure adherence and efficacy. Lifestyle modifications. Providers should also emphasize the importance of diet, exercise, and weight management as foundational strategies alongside pharmacotherapy. What strategies should primary care providers employ to assist patients in tobacco cessation? Answer. Primary care providers can employ the following strategies to assist patients in tobacco cessation. Ask and document. Providers should routinely ask about tobacco use and document smoking status at each visit. Advise. Offer clear, strong advice to quote emphasizing the health benefits of cessation. Assess. Determine the patient's readiness to quote previous cessation attempts and any barriers to quitting. Assist. Provide resources including behavioral therapies and counseling, as well as pharmacotherapy options such as nicotine replacement therapy (NRT) and prescription medications e.g. bupropion or varenicline. Arrange follow-up, schedule follow-up visits or calls to monitor progress, provide support and adjust treatment as necessary. Community resources. Refer patients to local cessation programs and hotlines e.g. 1-800 Quit Now for additional support. What are the screening recommendations for type 2 diabetes in adults, including diagnostic criteria? Answer. Screening recommendations for type 2 diabetes in adults as recommended by the American Diabetes Association (ADA) include: starting age. Begin screening at age 45 or earlier for those with risk factors such as obesity, family history of diabetes, sedentary lifestyle, or certain ethnic backgrounds. Frequency. If results are normal, screening should be repeated every 3 years. Diagnostic criteria. The following criteria can be used to diagnose diabetes. Fasting plasma glucose FE was 120 ddl 7.0 ml after fasting for at least 8 hours. 2-hour plasma glucose during an oral glucose tolerance test OT equals 100 mdl 11.1 ml using a 75 grams glucose load. ACE equals 6.5%, 48 mmol. Confirmed by repeat testing unless symptoms are present. Random plasma glucose equals 100 mdl 11.1 ml in a patient with classic symptoms of hypoglycemia or hypoglycemic crisis. A 60-year-old male with a history of type 2 diabetes presents for a routine checkup. His HbAC is 8.5%. What adjustments would you consider for his diabetes management, including lifestyle changes and pharmacotherapy? Answer. For a patient with an HbAC of 8.5%, adjustments to diabetes management should focus on both lifestyle modifications and pharmacotherapy. Lifestyle changes, dietary modifications, encourage a balanced diet rich in whole grains, fruits, vegetables, lean proteins, and healthy fats. Implement carbohydrate counting or portion control to help regulate blood sugar levels. Physical activity. Recommend at least 150 minutes of moderate intensity aerobic exercise per week, along with resistance training twice a week. Pharmacotherapy adjustments. Medication review. Assess current medications for efficacy and adherence. Consider adjusting dosages or switching to more effective medications if HbAC targets are not met. Addition of new agents. If not already on a EN receptor agonist or DELT inhibitor, consider adding one of these classes as they provide cardiovascular and renal benefits. Insulin therapy. If the patient is on maximum oral therapy and still has elevated HbAC, consider initiating basal insulin therapy. 45-year-old woman with a history of alcohol use disorder presents with jaundice, abdominal distension, and confusion. What initial steps would you take in evaluating her condition, and what diagnosis should be considered? Answer. Given the presentation of jaundice, abdominal distension, and confusion, the initial evaluation should focus on assessing for acute liver failure or alcoholic hepatitis. Key steps include clinical assessment, conduct of thorough history including alcohol intake, duration of use, and any previous liver disease or related complications, laboratory tests, liver function test LFTS, evaluate AST, ALT, alkaline phosphatase, bilirubin levels, and INR to assess liver function and degree of liver injury. Complete blood count, CBC. Check for thrombocytopenia, which may indicate portal hypertension or hypersplenism. Imaging studies. consider an ultrasound of the abdomen to evaluate liver size, echogenicity, and the presence of ascites or liver lesions. Consideration of diagnosis. Given the history of alcohol use, alcoholic hepatitis is a likely diagnosis, particularly if LFTs reveal markedly elevated Astolp ratios 2:1 and elevated bilirubin levels. A 32-year-old male presents to the emergency department with fever, cough, and purulent sputum. The chest X-ray shows a right lower lobe infiltrate. What factors should guide your choice of antibiotics, and what are the recommended agents for community-acquired pneumonia? Answer: when selecting antibiotics for a patient with community-acquired pneumonia (CAP), consider the following factors. Risk factors for resistance. Evaluate the patient's age, comorbidities e.g. COPD, diabetes, recent antibiotic use, and any history of hospitalization in the last 90 days. Severity of illness. Assess the need for hospitalization based on clinical criteria e.g. CUB-65 score. Higher scores may warrant more aggressive treatment and potential inpatient management. Recommended antibiotics for outpatient treatment of previously healthy individuals with no recent antibiotic use. First-line options include azithromycin or doxycycline. For patients with comorbidities or recent antibiotic use, consider levofloxacin or amoxicillin clavulanate in combination with azithromycin. Follow-up. Schedule a follow-up appointment to reassess symptoms after 4-8-7 hours and adjust treatment based on clinical response. 50-year-old woman with newly diagnosed hypertension presents for management. Her blood pressure is 150/95 mmHg and she has no significant past medical history. What initial lifestyle modifications and pharmacotherapy would you recommend? Answer: for a patient with newly diagnosed hypertension, 150/95 mmHg, a comprehensive management plan should include both lifestyle modifications and pharmacotherapy. Lifestyle modifications. Dietary approaches. Advise a DASH dietary approaches to stop hypertension, emphasizing fruits, vegetables, whole grains, and low-fat dairy, while reducing sodium intake to less than 2300 ng/day. Weight management. Encourage weight loss for overweight individuals, aiming for a body mass index (BMI) below 25 kg. Physical activity. Recommend at least 150 minutes of moderate aerobic exercise per week. Pharmacotherapy. Start with a thiazide diuretic e.g. hydrochlorothiazide as the first-line agent, especially for uncomplicated hypertension. Consider additional agents e.g. ACE inhibitors, calcium channel blockers if blood pressure remains elevated after lifestyle changes. A 75-year-old man presents with fatigue and pallor. His CBC shows a hemoglobin level of 9 g/mol with microcytic hypochromic red blood cells. What is the most likely diagnosis and what initial diagnostic tests would you order? Answer: the presentation of fatigue and pallor combined with a CBC showing microcytic hypochromic red blood cells suggests iron deficiency anemia as the most likely diagnosis. Initial diagnostic tests should include iron studies, serum ferritin. Low levels indicate depleted iron stores, serum iron and total iron binding capacity (TIC). Low serum iron with elevated TIBC is characteristic of iron deficiency. Reticulocyte count. This test assesses bone marrow response. In iron deficiency, reticulocyte count is typically low. Peripheral blood smear. Evaluate for additional features such as anisocytosis, variation in red blood cell size, and poikilocytosis, variation in red blood cell shape. Consider additional testing. If iron deficiency is confirmed, further evaluation may be necessary to identify the underlying cause, e.g. gastrointestinal bleeding, dietary deficiency.